Good afternoon. My name is Aziz, one of the trainees in West Midlands. Thank you for listening to me today. I'm going to talk about our experience in tricuspid valve repair over a period of six years. Just a quick recap on quite important points about the pathology or the disease of tricuspid valve repair, and that it's mostly associated with the left-sided valvular disease, and most commonly is a functional in nature. Uncorrected tricuspid valve regurgitation did show to be associated with a higher mobility and a poor prognosis for the patients. So when we went on to have a look at our cohort of patients at the University Hospital Coventry and Warwickshire NHS Trust over a 6-year period, and we looked at all our tricuspid valve repairs, but excluded those who have a tricuspid valve disease due to sepsis or those of organic nature, as in a non-functional cause of regurgitation. We looked at our systemic database, mostly some case notes when needed, and we also had a look at the systemic database in other hospitals, the referring hospitals, as well as obviously the echocardiographic reports. We managed an 82% of follow-up and of a median of 372 with an interquarterly range of 290 days. Please excuse this busy slide, but essentially this is a preoperative characteristics of our patients divided by the type of repair they had. So they have bicuspidization, ring annuloplasty, divega, and other that were not defined in our database. And I've highlighted here some of the important factors that have been previously looked at in previous studies that show they may or may not affect the quality of repair or the prognosis of the patients. And it showed one of the three most important ones showed that there is no difference in our patients preoperatively, and same goes for the rest of the preoperative characteristics. As tricuspid valve repair or tricuspid valve disease is usually associated with left-sided heart disease, these are the concomitant operations, and you can see most of our operations, 18 plus 47%, were associated with a mitral valve disease and mitral valve repair, which was undertaken. There are some isolated tricuspid valve coming with a coronary artery bypass grafting or a maze procedure, and there are some aortic valve. The replacement in this cohort was just under 1%. So this is a slightly complicated graph, but basically this is essentially looking at a grade 2 or grade 3 or more of tricuspid valve regurgitation. Preoperatively, for each of the type of repair, within 60 days of repair, and at follow-up of our median, which was just over a year. And essentially it shows that in our cohort of patient, somehow the ring annuloplasty showed a significant factor of a higher recurrence of grade 3 or more at follow-up for tricuspid valve regurgitation compared to the other two repairs. When we looked into some factors for those who had a recurrent severe, moderate to severe degree of tricuspid valve regurgitation, these were the three elements that has shown to be significant in our cohort of patients, which included obviously a poor left ventricular ejection fracture, a high systolic pulmonary artery pressure, and the degree of preoperative mitral valve regurgitation. Just a quick going through some numbers of other complications. A new onset postoperative SVT, mostly atrial fibrillations, and these are the patients who did not have atrial fibrillation pre-operatively. Lower respiratory tract infection, severe in nature, that required some form of mini or a surgical tracheostomy and a readmission to ITU, about 5%, and renal failure that did not require a renal replacement therapy in the range of 14%, and 5% required CVVH, and our 30-day mortality were 5%. In our cohort of patients, the bicuspid dilatation technique, which we believe is a quite reproducible and safe technique, showed a lower risk of recurrence in our patients. And the predictors of severe tricuspid regurgitation at follow-up were the LV function, the preoperative degree of mitral valve regurgitation, as well as the preoperative systolic pulmonary artery pressure. Obviously, this study does have some limitations, and I'd like to mention them quickly here. First of all, this is a retrospective cohort observational study, which comes with its own limitations. Our follow-up, we've achieved 80%. We would obviously like to achieve a bit more, which we are still working on that. We only completed about 80%, as mentioned, within just about a year of follow-up. Obviously, there's a difficulty here having to go through other hospitals and getting access to their database and echo reports for each of the patients, especially if you don't work in these hospitals. And lastly, we have a small number of patients who the type of repair was not defined and it was put as others. And that's what's mentioned in the fourth technique, and a lot of these patients were excluded from some of the analysis due to not knowing in which group they belong to. Thank you.